This conference.
Okay, so welcome to class, people. Many times I got a request from the people they wanted to do this class. Therefore, I decided for it. So what I'll be doing is I'll be just giving you some brief about SGA. Then we'll be doing SGA guideline. Then we'll be doing question. Okay, and I would require one person to volunteer. So because doing interactive class makes more sense than me speaking again. So anyone can volunteer. Okay, now like small for date, there are two type of issues are there, like baby is SGA, but it doesn't mean that baby have got fetal growth retardation. Okay, so now you can see from this chart. So here they have, this is the like they have, this is the baby's head circumference, and this is abdominal circumference. And if you see both the, this head circumference and the abdominal circumference, both of them are in the lower side. Okay, so this baby has got no growth retardation, but baby is small, baby is constitutionally small because of genetics or because of anything, baby meant to be small. Okay, so this kind of baby usually they will go do well because there is no growth retardation. Okay, now another set of baby where if you go through their like growth chart, you will find that their growth it is decreased, it falls down from like 95 fifth centile to fifth centile, or from previously better growth to now growth has become less. So this kind of baby, these baby has got fetal growth retardation. And what we are worried about this fetal growth retardation babies. Okay, now if you see these kind of baby, they have got asymmetrical, what we call previously we used to call this as an IUGR. So these kind of baby will have asymmetrical IUGR or FGR. So their head size will be normal, but their abdomen will be small. Okay, so this is the difference. So when the baby is SGA, their head size and their abdominal circumference both will be small. So there is no growth retardation. But in this kind of baby, where there had been asymmetrical FGR, there is a fall in the growth centile. So this kind of baby has asymmetrical IUGR or FGR, and their head size will be normal, but they will have a smaller abdomen. Therefore, whenever we are doing this growth monitoring, we always measure effective fetal weight, and also we measure abdominal circumference. Now a few things, if the asymmetrical FGR if the symmetrical FGR is there, so baby will be like head and trunk, both will be small. And these kind of usually symmetrical FGR occurs if something has gone in the early antenatal period. So when the organ development was taking place, so when it can happen, so you will find symmetrical FGR in the chromosomal abnormalities, congenital abnormalities, intrauterine growth infections, or environmental factor. Usually something has happened early in the pregnancy when the organogenesis was taking place. Okay, so this is symmetrical FGR. Now asymmetrical FGR. In asymmetrical FGR, usually some kind of pathology sets in, but it sets in later part of pregnancy. So it could be either preeclampsia, or it could be essential hypertension, or it could be maternal smoking, or it could be idiopathic. And what happens in this kind of FGR, usually the body tries to like adjust for its maximizing its chances of survival. And because of this adjustment, there is a redistribution of blood flow occurs. So more of the blood flow goes to the vital organs of the body of baby. So they will, it will go to brain, heart, and adrenal gland, and less blood goes to the liver, kidney. So abdominal girth and the fat stores are reduced than head. So this kind of effect, it is called as a brain sparing effect. So baby, that means there is a, this is an adjustment of body of the baby, so that causes the redistribution of blood flow. Therefore the vital organs of the body are getting more blood flow. So the head will be, head size you will find it will be more, but they are limiting the blood flow to the less vital part of the baby's body, like liver and kidney. They will be getting less flow, so there will be effect on the abdominal girth, and the fat stores have to be reduced. Okay, so this effect is called as a brain sparing effect. And why it is important to know about the little bit about brain sparing effect? Because if we see, when we do middle cerebral artery Doppler, in that part there, if the pi there would be change in the pi value, and that we can if the change is there in the pi value, then we'll be able to know, okay, the brain sparing effect has started. So this is this little thing that is important, because that will help in understanding the MCA Doppler. Okay, now what could be the reason? So it could be maternal factors for FGR, it could be maternal behavioral factors, it could be fetal factors, it could be placental factors. I will just sum up it, because sometimes you guys may get SB about it. Okay, so and in what form SB can come, that also we'll discuss. It is just an enumeration. So maternal factor, it could be chronic hypertension, connective tissue disorders, in chronic infection, diabetes mellitus, anemia, maternal malignancy, preeclampsia, thrombophilia. Behavioral maternal behavioral factors could be problem with the smoking, with the nutrition, age, more than 35, alcohol, drugs, social deprivation. Okay, then fetal factor, again, if there is any chromosomal abnormality is there, any structural abnormality is there, any in the multiple pregnancy also it happens, then any congenital infection, inborn errors of metabolism. Placental factor, we already know it has to be either some abruption is there, some previa is there, choriomonitis is there, or placental cysts are there. Now, these are the usual factor, but RCOG guideline, like guideline number 31, what we are going to discuss, they have put some more factors for SGA also. These are of African American, Indian, or Asian ethnicity. So it depends on the ethnicity also. Okay. Then nulliparity, first baby, body mass index less than 20, more than 25. These all are the factors you guys have to remember. And what the way it will be, you need to remember to solve question that I'll be explaining in the upcoming slides. Then maternal SGA, daily vigorous exercise, short pregnancy period, like two pregnancies are there less than 6 months of time, or longer period, two pregnancies are there more than 60 months. Okay, more than 5 years if the pregnancy is there. So this is a factor for SGA. Then any domestic violence, a low maternal weight gain, then caffeine consumption more than 300 milligram per day in third trimester, then singleton pregnancy following IVF. So these are the risk factor for SGA that are only that are present in that are there in the RCOG guideline. Now, what will happen if the FGR is there? So baby will be mostly the baby it will be preterm baby, because of the all these changes in the Doppler happens or something happens. So there could be possibility of a low Apgar score, hypoxia, need for respiratory support, admission in the neonatal care unit. There could be chronic lung disease. There could be necrotizing enterocolitis because of excessive oxygenation. There could be retinopathy of prematurity. Yes, morbidity and mortality has to be high. Okay, so this was the just brief. You guys are not getting any question from here. Now, what you have to know? So you have to know, because in this guideline, whatever the questions come, they're always, there is they're speaking about Doppler. So little basics of Doppler is required, because then the understanding and in the solving questions become very good, So usually there are three Dopplers. These are done. Most important Doppler for this SG or FGR is the umbilical artery Doppler. Another one is middle cerebral artery Doppler. Another one is uterine Doppler. Okay, so for us, the most important is umbilical artery Doppler. Now you can just see this. This is the normal umbilical artery Doppler. You can see this is the umbilical artery. Now this is the systole, and this is the diastole. Okay, so and uh, they and the ultrasound machine, usually when this graph is there, so and you put this kind of marker in on the machine, so some kind, some calculations will come automatically. Nobody is asking you this calculation in the exam, and no need to remember also. So what they calculate pi, pulsatility index, and they calculate ri, that is a resistive index. So this part you have to know. And the PSV is peak systolic velocity. So this will be the PSV, and the systolic velocity will be somewhere here. Okay, and this time averaged velocity will be calculated by a machine. Now what you have to know is these two terms you need to know, because these are used in the guideline. This is PI and RI. Okay, this is a calculation for PI, and this is a calculation for RI. Nobody is asking you, please don't remember. So what important, the thing that you have to know, normally what happens, this Doppler indices, they decline gradually with the gestational age. So normally it happens that RI and PI of umbilical artery will decrease. Okay, so this is the normal pattern. But what happens in the SGA baby, instead of increasing, instead of decreasing with the age, they increase. Therefore, when you will see that chart that is given in the guideline, they will say uh, like RI or PI more than 2 standard deviation, or sometimes they will write more than 95 centile. Okay, so therefore it is important to understand. So what is normal? So I'm repeating it again. So normally umbilical artery indices gradually decrease with gestational age. So this is normal. Just you remember that. Then the abnormal thing, then you will be able to understand it better. Now this is again, this is not so you will find this three things. Now in the last part of your guideline, there are three tables. Okay, and that are depend on this Doppler only. So if this is not, so this is the umbilical artery Doppler, and systole and diastole. Now you can see there is a very good flow in the diastole, so it is normal umbilical artery Doppler. Why it is important, that will do when we do guideline. Then you will find in the second part of that chart, they wrote umbilical artery Doppler with absent diastolic flow. No, they wrote with the diastolic flow. Okay, so they were again speaking about this. So this is the normal when there is good systolic flow and good diastolic flow. Now if you go to third part of that chart, they two Dopplers they have put in together. So one, when the umbilical artery Doppler have got absent diastolic flow. Now you see it here. So this is umbilical artery Doppler, but there is no flow in the diastole. So it is absent diastolic flow. Okay. Now you will again find another term they use, reverse flow. So this is the umbilical artery Doppler when the flow is reversed. Now you can see it here. So this is the reverse flow. So nobody is asking you all these questions, only to better understanding of that guideline, what they want from you, that this is important. So I'm repeating it again. So this picture shows good diastole flow, and it is normal umbilical artery Doppler. This picture shows Doppler with absent diastolic flow. This picture shows Doppler with reverse diastolic flow. And just just understand this, no need to remember. Is it clear?
Yes, ma'am.
Okay. Now another term that would be used in the that table is MCA Doppler. MCA, you already know, it is the middle cerebral artery. So this is the normal picture of middle cerebral artery Doppler. Okay. So what happens, and these are the calculation done by the machine, but not important for you guys. So usually MCA Doppler, they calculate RI and PI value, and RI and PI value usually they decrease with the pregnancy. Okay, but if something goes wrong, then the values will instead of decreasing, they will be increasing. So MCA Doppler, the changes that happens with the pregnancy is opposite of umbilical artery Doppler. Okay, therefore you will find in the that chart, like if the MCAPI is becomes I think it is more than, so that sign is there, so that will help you understanding that. And also you will find one time in the guideline they are calculating CPR ratio. CPR ratio is the PI of MCA uh, over PI of umbilical artery. So usually in the normal babies it should be 1 or more than 1, but if it is SGA baby, so it becomes less than 1. Okay, so it happens. So like what what just now I explained about you guys about the brain sparing effect. So if the brain sparing effect started in the like SGA babies, then it will be picked by the MCA Doppler. So here it is an abnormal Doppler, but no need to know about like what is the abnormality and what is the thing, because nobody is asking you that. Only just brief is required to understand that guideline. Now what is important from this part, it is really important because you, that will help in solving questions. Now what happens, people just understand whenever the patient comes, you already know in there is a booking visit in UK, and it happens less than 11 weeks of pregnancy. So usually whenever the woman is coming for the booking visit, complete history is taken, like everything is done. So that time they do some risk assessment. Okay, in the risk assessment, why it is important, because they will find where they have to put this patient, in which pathway this patient will go. So now you see, this is a booking visit. It is the, it's usually less than 11 weeks. So they will ask for something. Now they categorize the factor in two parts. These are the minor factors and major factors. Okay, so now these are the list of minor factors. These minor factors you guys have to remember by heart. If you don't remember this factors by heart, you are not in a position to solve question. Okay, so this is the key. Now I would be repeating this question, this factors again. So maternal age equal to and more than 35, number one. Number two, IVF singleton pregnancy. Third is primigravida or nulliparity. Now BMI. BMI, if it is less than 20, okay, less than 20, or uh, or if it is more than 25 to 35. So this part would be confusing, but you have to remember, because more than 35 BMI, then it will come in major risk factor. Then low fruit smoking less than 10 cigarettes, low fruit take pre pregnancy, previous preeclampsia. People make mistake there. What people do when they solve question, they whenever they say preeclampsia, they think that is a major factor and they do the question wrong. But understand people, it is preeclampsia. Mistake is happen at this point. Then pregnancy interval less than 6 months, or pregnancy interval more than 60 months, or 60 months means 5 years. So these are, to solve these questions, you have to remember all these factors by heart, and you cannot forget even a single word from here. If you forget, then you are going to make mistake. Okay, then now you will have a question and you have to count the risk factor. And if the risk factor you find there are 3 or more than 3, okay, so what you will do, you will arrange an uterine artery Doppler at 22 to 24 weeks of pregnancy. Okay, now if it is normal, then there will be an uterine umbilical artery Doppler at in the 3rd trimester. But if it is a uterine artery is abnormal, then it will like at the serial growth scan and umbilical artery Doppler. What we do for as an SGA baby pathway, so all this part has to be done. Okay, so the now why where the people make mistake when they solve question, it is important because everyone makes mistake. Now this BMI thing, people will make mistake because they will mess up here, they will put in some major factor. If you don't learn it well, then people make a mistake in identifying this preeclampsia thing. Then people make mistake in putting Doppler thing, and also in number of weeks they will forget it. They will sometimes you will find in a question 22 to 24 weeks and you will mess up. So you have to remember this. Okay, so I'm repeating it again. Please remember this minor risk factor by heart. If you find in your question more than 3, then you have to arrange an uterine artery Doppler at 20 to 24 weeks of pregnancy. If it is normal, arrange a Doppler in third umbilical artery Doppler in 3rd trimester. And if it is in abnormal, then it will go towards the SGA monitoring pathway. Okay, is the thing clear? Because this you have to understand. From here you will be able to solve questions. So is it clear?
Yes, ma'am.
Okay, good. Now what you have to remember is this one again. Now you can't miss even remembering this. So this part you have to remember. So if the age is more than 40, now you see here the age was more than and equal, it is more than, yeah, it is more than and equal to 35. Here the age becomes 40, more than 40. Please remember, because here are the things you will make mistake. Then smoking more than 11, more than equal to 11. In minor it was 1 to 10 cigarettes. Then paternal SGA, maternal SGA, daily vigorous exercise, cocaine, previous SGA or stillbirth baby, this part. Then chronic hypertension, you will remember. So please remember, it is not preeclampsia, it is chronic hypertension. Here the people make mistake. It is diabetes with vascular disease, like if the nephritis is associated with the diabetes, renal impairment, chronic kidney disease or anything. And if antiphospholipid antibody syndrome is there, if heavy bleeding similar to period, if there had been heavy bleeding, pape, low pape, okay, low pape less than 0.4 mom. So these are the major risk factor. You have to remember this. You can't, otherwise question will go wrong. So I'm repeating it again. Major risk factor from history: maternal age more than 40, smoking cigarettes more than 11 or equal to 11, maternal SGA, paternal SGA, previous SGA baby, previous stillbirth, cocaine, daily vigorous exercise, chronic hypertension, diabetes with vascular disease, renal impairment, antiphospholipid antibody syndrome, heavy bleeding like periods, or PAPE less than 0.4. So if you find any of this factor, then it is a major risk factor. If you find major risk factor, then this will be your answer. Serial assessment of fetal size and umbilical artery Doppler from 26 to 28 weeks of pregnancy. And same the wordings you will find in the questions. Okay, they will write same thing and you have to remember same thing. Now if you find like your 20 week scan, echogenic bowel is there, it is also a major risk factor. So answer will come from here only. Now if you find that woman has a larger fibroid or BMI is more than 35, you are not in a position to do symphysiofundal height for these patients. This is also a major risk factor, so it will be put in this pathway. Now one thing again, in the third trimester, so this was for the booking visit. Now in the third trimester, if woman develops preeclampsia, now understand, here it is third trimester preeclampsia in this pregnancy, then it becomes major risk factor. So it will, so answer will be serial assessment of size and umbilical artery Doppler, and if it has been abruption APH in third trimester. So these are the two things from third trimester. Okay, if the preeclampsia and unexplained APH and abruption, then your answer will become serial assessment of size and umbilical artery Doppler. Okay, so this you have this table, you have to remember by heart. You can't even miss even a single word from this, because all questions are gathered here. Now another place from where you will find questions would be this table. Now what they will give in the answer, they will say umbilical artery Doppler we have done and it is normal. So usually they ask you what you will do next. Okay, so this would be your answer. So now Doppler is fine, we are very happy. So, but we can't leave this pregnancy. What we will do? We will do every 2 weeks AC and EFW and UA Doppler. Okay. So now if the umbilical artery Doppler in our patient has become normal, so we'll call her every 2 weeks for AC, EFW and UA Doppler. Okay. But if we find that our patient is more than 32 weeks, then we can consider MCA Doppler also. Now, one thing you have to understand, MCA Doppler helps in understanding or deciding for like term baby. Okay, and ductus venosus Doppler helps in deciding the time of birth for preterm baby. These two part, you have to remember only. Then now your monitoring is going very well, and every monitoring you find that the umbilical artery Doppler is normal. But what you will do, you have to do something for this. You can't let this pregnancy grow continuously. So what you will do, you will offer delivery by 37 weeks. You will recommend delivery by 37 weeks if you find PI, MCA Doppler PI is less than 5. Okay, so now you see, uh, in MCA Doppler, PI has to increase normally. Normal is increased in PI, but here it has decreased and it has become less than 5th centile. Okay, so decrease in MCA PI is not good. So we have to do something. We'll take out this baby. So we'll recommend delivery by 37 weeks. We can't let this pregnancy grow more. So we have to recommend to this patient. And if we find that from over last 3 weeks maybe growth is same, so we have to do something. What we'll do, we can consider delivery by 34 weeks. And if the cesarean section we are offering, so like less than 38 or 38 weeks, so we have to offer steroid injection, that we already know. So you will find many questions that will be answered only from this table. Many questions will be answered from this only. Okay, so I'm repeating the thing again. Umbilical artery Doppler has come normal today. Please call your patient after 2 weeks, because you have to do AC, EFW and UA Doppler every 2 weeks. Now, if your baby, if your pregnancy is 32 weeks, you can ask for MCA Doppler as well. Now, what will be your action plan? You have to offer delivery by 37 weeks, recommend by 37 weeks if your MCA Doppler is less than 5th centile, because you can't let this pregnancy grow further. you can even consider delivered by 34 weeks if the baby is not growing well from last 3 weeks and the growth is static. Steroid thing you have to do if you are doing cesarean section. So this is the sum up, and if you do remember this, your questions are going to be correct all the time. Any question, guys, from here? Any question? Any question? No question.
Doctor, I think the follow-up is 3 weeks to avoid the false positive rate. I think that I passed through this in guideline. Is it true or wrong?
What you are saying?
Follow-up by umbilical artery Doppler is 3 weeks interval, not 2 weeks. I think that I passed through this information through in the guideline so as to decrease the false positive rate. I think that.
I will tell you. Okay, I will, yeah, your question is, I will answer your question. Okay,
Okay,
I
ma'am.
answer. See, there are two things. If your umbilical artery Doppler is normal and baby is SGA baby, then you will do this AC and EFW UA Doppler every 2 weeks. But if your baby is normal growing baby and umbilical artery Doppler is normal, in that particular situation, your growth monitoring will be done 3 weeks, and uterine artery Doppler, like it can be done like in that particular situation, you have got suspicion, but the baby is not SGA, and you want to monitor growth of the baby. That time you will arrange for this scan 3 week time. If your baby is SGA baby, then you will arrange this growth scan and Doppler every 2 weeks. Have I answered your question? This is what you were asking.
Okay, ma'am. Thank you very much.
Now, second part of that table. Now, if your umbilical artery this is the umbilical artery Doppler. Uh, the end diastolic flow is there, but the problem is there in the indexes RI and PI. Usually in umbilical artery Doppler, normally it should fall, but it is increasing, so we are a bit worried about this patient. So what we have to do, some action plan. So our action plan will be like, we would call growth assessment of this baby, like AC and EFW has to be done every week. And but we can't let this patient wait for long time. So for Doppler, we will call her 2 times in a week. Okay, so if RI and PI showing changes and they are increasing, so we have to do something. So growth assessment every week and Doppler 2 times in a week we will be doing. So this will be our action plan, and we can't let this pregnancy grow for longer time. We have to deliver by 37, but the static growth is there. We can even consider by 34 weeks. And steroid, if we are offering cesarean section, we have to offer steroids. That part we already know. Okay, so this is the second middle part of that big table, and you will get a number of questions from here. I am repeating it again. If your Doppler is fine and the systolic flow is there, but your indices RI and PI, they are increasing, so you would be worried. So you have to do something. Please, so what you will do, you will do her growth scan every week, and you will do umbilical artery Doppler 2 times in a week. You will recommend delivery by 37 weeks. Even you can think of it, or you can consider if the growth is not uh, static, by 34 weeks. Steroid according to like what we are reading in our guidelines. So is the thing clear about this? You will get a line of questions from this slide. Is it clear?
Ma'am, please explain once. I'm getting little confused.
What is the confusion?
About the timing of delivery, ma'am. Recommended and considered.
Okay. Okay, I'll explain. So recommend means that baby has to come. There is no other way. Baby has to deliver by 37 weeks. This is recommendation. Now you may consider means you may change your plan. Like you are monitoring this pregnancy, and by 34 weeks you saw, this baby is not going big, this baby is not growing, and the growth is same. I should do something for this. I don't want to wait for longer time. So you will consider, or you may consider by 34 weeks if the baby is not growing. Because in your usual practice also, when you monitor a patient and baby's growth is same, and the Doppler is showing some changes, you will take out this baby. You will consider take out this baby. Isn't it, Nivedita?
Yes, ma'am.
Same thing is there.
Got it. Got it, ma'am. Got it. Yeah.
Okay.
Yeah,
Consider means you may change
the
your
plan which
plan.
I have already decided. Yes, ma'am. I got it. Got
Yes.
it.
And all this recommend, consider why you have to learn, because part 2 question you will find the same type of wordings used, and if you don't remember it well, then you're going to make mistake. Now last part of the table is this is AREDV. This A is absent diastole flow, and R is reverse flow. So this is bad condition, this is very bad condition. You have to do urgently something. So what you will do, you will call this patient every week for growth. Okay. And if you you will do her Doppler daily Doppler, UA Doppler, UV Doppler, and you will do CTG, that is the computerized CTG. Okay. And as you are doing daily Doppler, so you can't let this baby grow more. So you have to recommend delivery by 32 weeks, before 32 weeks, like recommend delivery by 32 weeks after steroids. But if you are doing a scan and if you find there had been abnormal changes in the Doppler, in ductus venosus Doppler, if there had been abnormal change, ductus venosus Doppler will be the, if it is showing changes, that means it is in, something is going to go wrong very early. So you have to take your call and you have to take out this baby. Otherwise this baby you will going to lose this baby. So ductus venosus Doppler has got that much importance. Okay. So ductus venosus Doppler, usually what it shows, it shows reverse wave or something that will come in the guideline. So if your ductus venosus Doppler is showing some changes, or if the CCTG is showing some changes, then in this particular situation you have to consider, like you can deliver this baby before 32 weeks also. But pregnancy has to be more than 24 weeks, because that is a period of viability, and effective weight has to be more than 500 grams, because less than that, uh, it will be no use delivering this baby, because baby will not survive. Okay. And if you are putting this patient on the follow up, and UA, UV Doppler and CCTG, everything is going fine, then also please take out this baby by 32 weeks. Okay. So, and what they are saying, if sometimes if the ductus venosus Doppler is normal, you can even think if the baby is not growing well, by 30 in between 30 to 32 weeks of pregnancy. So this kind of baby, because you are doing daily Doppler in this baby, so like you can't make like that particular decision. So in this kind of when the absent or reverse diastolic flow is there, you are checking daily Dopplers, your UA UV Doppler, and also CCTG. So daily your you may change your decision. So what would be the recommendation if everything is going well? Okay, there had been no problem, then you will recommend delivery by 32 weeks. But if ductus venosus Doppler uh, is okay, but some baby is not growing well or some other issues there, you can think of even delivering it at like lesser time, in between 30 to 30 and in between 32 weeks. But on the other side, if if the ductus venosus, if any Doppler changes there or CCTG changes there, then what you will do if you can't continue by 32 weeks. In that situation, you will take out this baby. So when this kind of situation is going on and you are monitoring it daily, so your decision will change. But if everything is going fine, then also you will try to prolong this pregnancy by 32 weeks. And if you have to take out this baby will come by cesarean section, and before cesarean section you have to give steroid cover. Is the thing clear in this? Because you will get question from this slide. Is it clear?
Yes, ma'am.
Okay, so what you guys has to remember to answer your question right, you have to mug up this, you have to mug up this, you have to mug up this, you have to mug up this and this. If this 5 slides you remember by heart and you don't read the guideline, you are going to do your all questions right. Now I would require one volunteer. One volunteer, I will ask question and answer will be on the screen.
Yes, ma'am. I will be the volunteer.
Okay, that's great. So what is the definition of SGA?
It is an
Babies
infant
weight?
born with a birth weight less than 10 centile.
Yes, so less than 10 centile is SGA. And if we have to do the abdominal circumference, so what will be the definition? It should be how, what will be the definition for us abdominal circumference?
AC less than 10th centile.
Yes, so SGA, we call the baby SGA if the weight is less than 10 centile or if the AC less than 10 centile. Okay, now what will be the severe SGA?
If estimated fetal weight or AC is less than 3rd centile.
Yes, so you will get question from here. Now what is the so after, out of this SGA, I just told you some babies will be constitutionally small. So what will be the percentage?
50 to 70%.
Yes, so 50 to 70% baby may be constitutionally small. So what is the definition of low birth weight?
If birth weight is less than 2.5 kg.
Yes. Now these are the factors where the baby can grow small. This I have already summed up or spoke. I already told you in the PowerPoint presentation, so I'm not speaking that again. Okay. Now, so when we do booking visit, we take history. So there is a major risk factor and minor risk factor. So what is the major risk factor? If the odds
When
ratio
the
is
more than 2.
yes. So if the major risk factor, if the odds ratio is more than 2, that would be a major risk factor. And what we will do, that I already discussed, serial ultrasound scan and umbilical artery Doppler from 26 to 28 weeks of pregnancy that I discussed. Okay, so what you will do if there are 3 minor risk factor?
We will do uterine artery Doppler at 20 to 24 weeks of gestation.
Yeah. Now, if the previous baby was SGA, so what is the possibility of having SGA baby in this pregnancy?
Twofold.
Yes. So if my previous baby is SGA and I'm pregnant this time, so 2 times there is a likelihood I will get a SGA baby. Okay, this part we have done. This part also we have done. Okay, so if the patient has come and she has come with the first trimester screening and her PAP is less than 0.4 MOM, so what type of factor it is?
Major risk factor.
Yes, so we will put this on a major risk factor pathway. So yeah, so the if the like abnormal uterine artery, usually what happens in uterine artery, we already know there is a trophoblast invasion. Because of this trophoblast invasion, changes occurs in the uterine artery Doppler. So if that invasion, trophoblastic invasion of myometrial spiral artery is inadequate, so in uterine artery Doppler there will be notching. Okay, there will be notching. So if this notching is there or abnormal flow velocity is there, then we call uterine artery Doppler as an abnormal. So if the abnormal uterine Doppler we find, so what we will do?
Umbilical artery Doppler at 26 to 28 weeks.
Yes. So if the abnormal uterine artery Doppler is there, so we have to do something. We'll do serial ultrasound for fetal size and umbilical artery Doppler for 26 to 28 weeks of pregnancy. Okay. Now, if the normal, if we find uterine artery Doppler and that is normal, so what we will do? We in that particular situation, we are not that so that serial size and serial assessment will not be done, but uh, they should be offered third trimester umbilical artery Doppler once. So they will not be put in a serial scan pathway, but they will be in third trimester one time umbilical artery Doppler will be done for them. Okay. Now, if the patient has come with the 20-week scan and you find baby has, they write fetal echogenic bowel. So, what type of factor it is? Echogenic bowel.
Major risk factor.
Yeah, it is major risk factor. Now, we usually do symphysis fundal height measurement from what number, which week of pregnancy?
24 weeks of pregnancy.
Yes, and there are whenever we plot this symphysis fundal height, it is important to plot in a customized chart rather than in a population based chart. Okay, so in customized chart, they take care with the ethnicity, height, weight. So so many things they take care. So it has to be plotted in a customized chart. And if you find that it is less than 10 centile SF symphysis fundal for height, if it is less than 10 centile, then what you will think and what you will do?
She should be referred for ultrasound measurement of fetal size.
Yes, like say she will be put in that SGA pathway. Now, if the BMI is more than 35, patient has large fibroids or patient has hydroamnios. So in this situation, symphysis-fundal height cannot be accurate. So patient has to be sent for the serial assessment of fetal size. Okay, this is another factor. Okay, this in the serial like AC, what they are saying, if you measure fetal AC or EFW one time in a third trimester, then in that particular situation you will not be able to find SGA baby, and it will not be reducing the able to reduce incidence of SGA baby, because you have to do it serially. If you do it serially only, then only you will be able to know that baby is not growing well, or if there had been a change in the growth. So someone was asking this question. Okay, now what they are saying, that the measurement of AC and EFW has to be 3 weeks apart. Okay, 3 weeks apart for the diagnosis of SGA and FGR. Now you will find question from this 3 weeks apart. Many times this question has come as SBA. And one thing I wanted to tell, like someone asked this question in the beginning also. So if we find normally growing baby, and in that situation we have to do scans so that we can assess the FGR, then the scan will be done 3 weeks apart, okay, for normally growing baby. But if we have already diagnosed the baby as an SGA baby, so it is a diagnosed baby, SGA baby, and we are doing growth scan for her, that baby, so it will be 2 weekly. So now the things would have been clear about this 3 weeks and 2 week thing. Okay, this is the one thing. So in last after 30 weeks of gestation, what do you think, how much AC abdominal circumference of the baby should be rising in 2 weeks or 14 days?
10 millimeter.
10 millimeter. And how much the weight baby will be gaining?
200 grams.
Yes, I have not seen question from there, but it was good, so I put it here. Now you will get a number of questions from here. Like this is full of questions. Now you have done a growth scan for a baby at 18 to 20 weeks. But if you find the baby has got severe SGA and uterine artery Doppler you find is normal, so what will be your next step? You will send baby for
Karyotyping.
Karyotyping.
okay. Now because if the baby is very small at such an early age and uterine artery is fine, that means it is a baby factor for SGA, not mother factor. So you will do karyotype. You will find this question many times in this answer many times in a question. Sometime you will find answer will be amniocentesis. So instead of karyotype, if they have not given karyotype in the answer choices, so your answer will be amniocentesis. So complete answer becomes amniocentesis for karyotyping. Okay, from this line you will find many questions. Now you will screen some some infections. So what would be the infection you will screen if you find SGA babies there?
Cytomegalovirus and toxoplasmosis.
Yes, you will find question from this line also. Then in high risk population, what testing more is required?
Syphilis and malaria.
Yes. Now in severe SGA baby, chromosomal abnormalities, what is the percentage? You will find question from here. This is a question.
19%.
Yes. And if SGA before 26 weeks, so what will be the commonest chromosomal defect?
Triploidy.
Yes. And if it is after 26 weeks, then
Trisomy 18.
Yes. So this is the area full of questions. So severe SGA chromosomal abnormalities 19%. Before 26 weeks triploidy, after 26 weeks trisomy 18. Okay, you will find question from here. Now fetal infection is responsible how much percentage of SGA?
5%.
5%. So these are the two percentages you have to remember. Now, so what number you have to remember from this guideline? If previous baby is SGA, so likelihood of this time SGA baby is 2 folds or 2 times. One number. Second number, incidence of chromosomal abnormality in severe SGA baby is 19%. This second number. Third number, 5% of the SGA baby will have fetal infections. So these are the three numbers that you have to remember from this guideline. So what do you think? This aspirin has got any role in SGA prevention?
Yes. Effect.
No. It is only there if the patient has got risk factor for preeclampsia. Okay. For all
Okay.
SGA, yeah, for all SGA, antiplatelet agent or aspirin has got no role. But if the patient, if you do risk assessment and patient has got a high risk factor for preeclampsia, then from your PET guideline or a nice PET guideline, you know, you have to start aspirin from the 12 weeks of pregnancy. Okay, so that that part only they are saying. So you know, from the PET guideline, so they have also put a um, moderate severe factor and moderate factor. If severe factor is there, then with the one risk factor, aspirin will be started from 12 weeks of pregnancy, and if two moderate risk factor are there, then aspirin will be started from 12 weeks of pregnancy. So these aspirin is only you have to give if there is that preeclampsia risk factors are there. So they will prevent preeclampsia also, and they will be useful for SGA also. But it will be given for those indications only if whatever given in the PET guideline. Okay, and what they are saying, there is no role of diet modification, progesterone, calcium in SGA baby. Okay, so there is no role. So, and what they say, if the woman is smoking, then stop smoking or smoke cessation, it do have a very good role. So and what they're saying, if they have, I don't know, it will go like if the woman has stopped smoking by 15 weeks of gestation, then they could reduce this back to that of non-smoker. Maybe you will get question from here. So if they stop smoking by 15th week of gestation, then this risk of smoking as an SGA will be like normal. So at if the SG baby is there and you have to deliver them, so at what weeks of gestation you will give steroid?
Between 24 and 35 weeks.
35 weeks plus 6 days. Okay, you have to remember this.
Yes.
Okay, so this part I have already done in the slides. So so I won't be repeating it again because there would be confusion. I will sending the screenshot of that slide from where the question comes. Now, if this computerized CTG they are doing, so what they measure short-term variation. So if the short-term variation is less than 3 ms, then there is a high rate of metabolic acidemia. I don't think so I have seen ever any question from here, but still you have to know this, because this may, if the CCTG computerized CTG is showing short-term variation less than 3 millisecond or equal to 3 millisecond, then there is a very high chance of metabolic acidemia. Now, what is the recommendation? They measure amniotic fluid volume. So what is the recommended method? How they measure it?
Single deepest vertical pocket.
Yes, you will get question from this also. So if it is less than 2, then it will be oligohydramnios, and if it is more than 8, then it will be polyhydramnios. Okay, this I was saying. So if the brain sparing effect there in the middle cerebral artery, so if we have to take some decision, then we can do middle cerebral artery, but it is only effective in the term baby. So if the brain sparing effect is there, what I discussed before in the slide, then there will be like a change in the Doppler, there will be decrease in the PI of MCA. And if the reduced MCA PI is there, then in that situation, we will be able to know that the brain sparing effect because of the chronic hypoxia has already been started. Okay, this is just for a knowledge. The question doesn't come from here. Now, this ductus venosus Doppler has effect predictive value if the preterm SGA is there. So if the baby is preterm, we usually monitor them by ductus umbilical vein and ductus venosus Doppler. And if there is a retrograde A wave or pulsatile flow in umbilical vein, that is like a very bad sign. There is a possibility of overt fetal cardiac compromise. So you have to take out this baby. Sometime you may find question from here. So if it is a retrograde A wave or pulsatile flow in umbilical vein, then you have to take out this baby early, immediately. Okay, so if the patient has come with the absent or reverse artery Doppler, so by what way the delivery can be done?
Caesarean section is
Yes,
recommended.
because this baby cannot bear the stress of vaginal birth, so absent or reverse diastolic flow, take the baby for cesarean section. But in all other condition, when the end diastolic flow is there, IOL can be done. Okay, IOL can be done with a continuous heart monitoring, but there is a very high chance of emergency section here. And if there is a spontaneous labor, a patient is there with a spontaneous labor, diagnosed SGA baby, so would you admit her early?
Yes.
Yes. So if there is a diagnosis of SGA baby and the patient has come in the spontaneous labor, you have to admit her immediately and start with a continuous fetal heart monitoring. Okay, okay, this part also you have to remember. Now you see this table, most of people you will forget going through this table. This table is important. Why? Now they say if OR ratio is more than 2, then it becomes a risk factor. So now you see here. So I have put the mark here. So more is the OR value, higher is the possibility that factor would be responsible for FGA. Now, if you see table here, so the like previous stillbirth, it is 6.4 OR. Now you can see so much weightage to this factor, and another is 6.2 antiphospholipid antibody syndrome. Now you see 6.2. So if you in sometime what they do, usually they give many factors, then they want then they ask you which factor the more chances baby having SGA. So this OR thing will help you in answering that question. So you can't remember whole table, that is real not possible for anyone, but this sixth thing When the OR is 6, that you can, that three or four things you can remember. So higher OR, 6.4 is previous stillbirth. So previous stillbirth is a like killer. Second OR is 6.2, that is antiphospholipid antibody syndrome. And third 6 is diabetes. Okay, diabetes with vascular disease. So if I take that in a decreasing order, so highest OR is for previous stillbirth. This will be followed by antiphospholipid antibody syndrome. This will be followed by diabetes with vascular disease. Okay, so you just keep this in your mind, because sometime you will get question from here. Apart from this one, you can remember this also. Unexplained APH is 5.6. Okay, so this minimum, this knowledge is important, because sometimes they will give you SPA with all choices will be there, and you have to find which of the factor have got highest probability of baby having SGR. That can only be answered with this table. This part I have explained already, and this also I have explained. So that's all about guideline. So any one of you have got any questions about the guideline can ask me. Any question? If no question, then I will start asking question. Any question? You guys not understand anything? No question, then it is good. So now you start answering my questions. Answer.
Consultant-led care in a high-risk pregnancy clinic and serial growth scans.
Yes, very good.
Ma'am. Yes.
Now, yes. So what is the explanation? Previous SGA. Okay, so we already know that previous SGA is a major risk factor, and if the major risk factor is there, so we have to do serial scan and umbilical artery Doppler. So the answer becomes this. Very good.
Administer corticosteroids.
A, ma'am.
Yes. Why? Because now explanation, already absent flow is there. If the flow is absent, we have to take out the baby by 32 weeks. Here it is already 32 weeks, so take out the baby, steroid and cesarean section.
Mom B. Referral for ultrasound after single SFH of below 10 centile and then serial measurements.
What you said? Which answer?
B, ma'am.
Yeah, B. So in this particular situation, she is nullipara, and so there will be no major risk factor is not there. So if, midwife will be doing care for her. Anytime if the symphysiofundal height ratio it becomes less, then they have to refer her.
Ma'am, I have a doubt.
This
What is the meaning of maternal SGA?
Okay, mother was a small baby.
Okay.
Please, ma'am.
It will
Previous
not
question, please.
include the maternal side. Family history is there. That will not be included in maternal SGA.
Maternal SGA means mother was SGA. Ma was
Okay,
like
madam.
there. Is it clear? Mother is a small baby or father is a small baby is paternal SGA.
Yes, yes, clear, madam.
Ma'am, for D, category 1 C-section.
Yes, because now you see station is -2 and CTG is showing changes. You have to do cesarean section. So these are the options. This is the question. Options.
Could be M, ma'am.
M. Serial
Serial
growth
growth
scans.
scans and
So
Doppler.
normal, yes. So if the normal Doppler is there, we have to call our patient every 2 weeks for a growth scan and Doppler. So this is the question. And these are the options.
Back the question, please, ma'am.
Uterine artery.
Ma'am, question again, please. Ma'am, options.
Oh, ma'am.
Ma'am, uterine artery
But
Doppler.
that's a major risk factor. So serial growth scan.
Yeah, it is.
So it's a major risk factor. So it will go major risk factor pathway. Okay. Is it clear?
Yes, ma'am.
So this is the question.
Same, madam. Major risk pathway. M.
Major risk. So now you see uterine artery Doppler is normal and IUG are 20 weeks.
Yes, yes.
I just
They
explained
made
this.
they made it confusing by writing fetal bowel is echogenic.
Okay, yeah, you are right. But now see the 20 week symmetrical IUGR. So karyotyping would be the answer. So this is the question. This is the options.
Question, please. Options, madam.
Betamethasone, 12 milligram 2 dose.
Category,
Yes, betamethasone.
category 2 CS.
It has to be CS.
With
It's
corticosteroid
showing
first.
reverse diastolic flow.
So here it is a reverse
D,
diastolic
D.
flow. So if the reverse diastolic flow is there, you have to give steroids and take out this baby. So take out this baby option will become category 2. Okay, what the answer is G, immediate LACS with a neonatal support.
Ma'am, but we will not
Unable
going to
steroid?
give betamethasone 12 mg before that.
Yeah, but
But there is no option which is saying both steroid and CS.
Yeah, that's what. But ma'am,
yeah,
considerably, we have to first give steroid and then we have to take out the baby, right?
yeah, you are right. So in this
But
particular situation,
definitively, ma'am, definitive will be CS only if we have to select a definitive treatment for this situation.
it has to be cesarean section. See, if they have given cesarean section with steroid cover, then that will be the answer.
The
But
best
if they
answer.
have, yeah, this is the best answer. But if they have given steroid one option and cesarean another option, then you have to choose cesarean, because
Okay, ma'am.
if you choose steroid, that means you will just give steroid and leave this patient, but you are not
Okay,
leaving
ma'am.
this.
No, exactly.
Clear?
Yeah, ma'am. Yeah. But we have to choose the definitive treatment which is to be given to the patient.
Yes.
Okay, ma'am. Okay, ma'am. Got it.
Cesarean by 32 weeks.
32.
Yes.
C.
Induction of labor at
Induction at
37.
37 weeks.
Yes.
A. Serial growth scans from 26 to 28.
Why?
There is one major risk factor. Pregnancy interval is 8 years, more than 5.
But that is not a major factor.
B.
Then it should be D, madam.
Then it should be D. Why D? Give answer.
She is 36-year-old, one risk factor.
Very good.
Another is interpregnancy interval.
Very good. Third. Third is BMI.
BMI.
BMI is
BMI, right.
28. So BMI in between 25 to 34.9 is minor risk factor. When I was peer teaching, I told you people make mistake here, and therefore this mistake happens. Okay, so be careful. You have to remember this by heart. Now she has got 3 risk factor: age, BMI, and more than 60 months interval between pregnancy. 3 risk factor. She will go to uterine artery Doppler. So answer is D. So it is simple mathematics. Questions are simple mathematics. Just remember their like pathway, what they want.
C.
Why?
Age more than 40 years.
E.
Major risk factor. Daily vigorous exercise.
Yes. Daily vigorous exercise.
E. Smokes.
E, mom. E, mom.
E.
Which is not a major risk factor.
Cigarettes more than
Sir,
10
E is
is a major
cigarettes,
risk factor.
10 cigarettes.
Yeah. So now see, questions are there only from these tables.
Fortnightly umbilical artery Doppler.
Yes. So now, if the Doppler is normal, we call patient every 2 weeks. So this is the question. And these are the options.
J.
Could be J, mom. J.
YJ. YJ. Read question again. Is this a SGA baby?
No, it will be normal.
Her previous baby was SGA baby. This baby is 50th centile.
Growth scan in 3 to
Growth
4
scan
weeks.
3.
Yes.
But
So
madam, previous SGA is also a risk factor, isn't it? That is a major risk factor. So shouldn't
yes,
be
you are right.
she should be in the major
Yes, mom.
Yes, you're right. Yes. So answer it should be like so it should be J.
Yes, ma'am.
Growth. It should be
yes,
J.
madam.
Okay. No, it's a normal. It could be I also because growth scan umbilical fluid and uterine umbilical artery Doppler. But if it is normal, then it is 2 weeks. So it should be J. This is the question and these are the options.
Ma'am, question please.
Serial growth
Options, madam.
scan.
Serial growth scan. And
This should
Doppler.
also be, I
J.
think, J.
Yes.
2
So
weekly Doppler.
normal Doppler, call the patient after 2 weeks.
Daily USG. Daily Doppler.
C.
A, ma'am.
No. See here. There is no diastolic flow is not there. So if diastolic flow is not there, preterm baby. So you have to do decision. What you will do? Which Doppler help in deciding in preterm baby?
Ductus venosus
Ductus
Doppler.
venosus.
But
Yes,
ma'am,
ductus.
it is written that Doppler should be done twice weekly. That also is there, no? In
No.
there.
It's in this
Daily
there is
Doppler.
absent diastolic flow. So it
Yeah,
belongs to
yeah. Mhm.
it is absent.
Okay, madam. Okay. Yes, yes.
If it is, see, if it is absent, you have to do something. You have to monitor it. So you will do it daily. And if you have to take some decision to deliver, ductus venosus will help you. So ductus venosus Doppler will be answered.
Some question.
Then twice weekly Doppler.
Yes, it should be 2 times. So it should be 2 times.
C.
This is the question. These are the options.
Ma'am, question.
Question. Options. Serial growth scan and Doppler from 26 to 28. L. Major risk pathway.
L.
Yes.
Karyotyping.
Yes. So answer is amniosynthesis for karyotyping.
Options.
Ma'am, can I see a question once again?
Options, madam.
Is it B? Customized symposium
The height
funded.
measurement. M.
Serial biometry.
See, suspected SGA ultrasound confirmed umbilical artery is normal. So if the umbilical artery is normal, then we call patient every
2 weekly.
answer would be K.
Okay.
But ma'am, she is just a suspected SGA. She is not a diagnosed
Confirms the
SGA.
diagnosis.
That
Ultrasound
was
confirms
also,
the diagnosis.
ultrasound confirmed that it was normal. So that means SGA was not there.
No, it confirms the diagnosis of SGA.
No, if the
Report.
SGA is
No, it
suspected,
is
Okay,
normal.
fine.
Ultrasound
We
reports normal
misread
like
the
volume,
question.
and umbilical artery Doppler is also normal. That means it is not a SGA.
no, if
It
if a suspicion of SGA is there, by midwife would have suspected SGA by symphysiofundal height. Okay, only they can measure that. So that suspicion has come. Therefore, with this they have put to the umbilical like this the serial growth pathway, and but the doctor find Doppler is fine. So answer will be from this only. Okay, they have not
Okay,
given
ma'am.
that part how midwife suspected, but it is from SFH only. Okay, she might have plotted that growth symphysiofundal height customized growth chart. She will find that it is less than 10. Therefore, she had sent it to the doctor. Is it clear?
Yes, ma'am.
Ma'am, question. Two weekly scan.
same answer, ma'am. Serial biometry every 14 days with Dopplers.
So yeah, it has to be C. But the book so the book answers are wrong. So it has to be growth scan. 2 weeks. normal Doppler, normal baby, but still as the suspicion is there, so it will come K.
Ma'am, this is which book?
In this book, many questions are wrong, answers are wrong. This is
Okay.
Justin Conji.
Conji,
Justin Conji.
ma'am.
Okay, so as a Doppler, normal Doppler, so it will be okay, not 32, it will be 2 weeks. Okay, so like that's all. These are the all questions. So to sum up, if the umbilical artery Doppler is normal, call this patient after every 2 weeks. If the umbilical artery is normal, but the RI and PI showing changes, call this patient 2 times in a week for Doppler and weekly for growth scan. And if the absent or reverse diastolic flow is there, then like monitoring growth scan weekly and Dopplers and umbilical artery and this umbilical vein and CCTG has to be done daily. So this is the sum up. Okay, so that's all about it. So if any one of you have got any question, can ask me.